Modern oncology has achieved a clear success. Treating cancer extends lives. As a result, we now have a massive, rapidly expanding cohort of post-treatment patients. But extending life exposes a secondary clinical challenge: sustaining long-term metabolic health. This chart plots the survivor population against standardized diet quality scores. While survivor numbers climb, diet quality remains stubbornly flat. This depressed baseline correlates precisely with climbing rates of cardiovascular disease, metabolic complications, and obesity. Nutrition dictates body weight, sarcopenia, and overall treatment tolerance. Yet, in routine clinical practice, dietary guidance remains heavily marginalized, treated as an optional lifestyle modification rather than a core medical intervention. A 2024 umbrella review by Lee and colleagues in the Journal of Nutrition directly evaluates this gap. The researchers pursued a dual objective: map out exactly what major U.S. oncology guidelines actually recommend, and then test the empirical strength of the evidence beneath those recommendations. The central tension is whether the dietary advice issued by our largest oncological networks is actually supported by distinct survival outcomes, or if it relies on assumed benefits. The data shows that the strongest survival signals come not from isolated nutrient targets, but from high-quality overall dietary patterns. Acting on that evidence requires clinical networks to physically engineer nutritional support into their systems, rather than handing out generic advice. For the modern survivor population, nutrition is a mechanism of chronic disease management. To understand the policy landscape, researchers extracted guidance from 5 major U.S. institutions: the ACS, AICR, National Cancer Institute, NCCN, and ASCO. This timeline illustrates how the clinical mandate is bisected into 2 nutritional zones: active treatment and post-treatment survivorship. During active therapy, the consensus is pragmatic. Guidelines prioritize managing symptoms. What stands out is the missing element. This phase lacks specific dietary patterns. The physiological goals here are immediate: preserve lean body mass, correct severe deficiencies, and maintain basic weight stability while the body metabolizes toxic therapeutics. The American Cancer Society provides the only strict operational detail for this phase. They mandate continuous malnutrition screening and explicit protocols for escalating to feeding tubes. Once transitioning into survivorship, guidelines converge rapidly into a single template. It's essentially a general cancer prevention diet repurposed for survivors, demanding plant-forward eating, whole grains, and severe limitations on red meat, ultra-processed foods, and alcohol. The clinical weakness here is a lack of specificity. Relying on a broad chronic disease model, guidelines aren't tailored to specific cancer types, unique metabolic phenotypes, or physiological damage from treatments. The tight consistency across these 5 major guidelines reflects behavioral simplicity and broad applicability. It does not reflect high-resolution metabolic precision. To test if that broad advice is supported by clinical reality, the review aggregated dietary literature published since 2010, starting with 1,540 individual records. Rigorous deduplication and screening isolated only the highest-tier systematic reviews and meta-analyses, narrowing the field down to exactly 14 eligible studies. The authors then applied the AmStar2 appraisal tool, a strict mechanism for grading methodological quality. This filter strips away critically low-quality studies, leaving only a small minority of meta-analyses rated as moderate or high quality. High publication volume doesn't equate to clinical certainty. The literature is dominated by observational cohort studies, lacking the rigorous causal proof of randomized controlled trials. These surviving cohort studies are highly vulnerable to residual confounding variables. A patient's outcome might be influenced by their socioeconomic status, baseline exercise habits, or smoking history, factors difficult to fully isolate from their diet. The data is also skewed by healthy user bias. Cancer survivors who deliberately follow high-quality diets often exhibit better healthcare engagement, muddying the exact survival impact of the food itself. The evidence carries a severe anatomical skew. The vast majority of high-quality dietary data is derived from just 2 populations: breast and colorectal cancer survivors. Cohorts for hematologic, head and neck, and gynecologic cancers are vastly underrepresented in the surviving literature. Survivorship is not biologically uniform. Extrapolating broad dietary mandates from breast and colorectal patients across different oncological phenotypes carries a distinct clinical risk. This matrix tests the available dietary approaches against 3 clinical outcomes: all-cause mortality, cancer-specific mortality, and recurrence. The strongest empirical signal in the review emerges right here: the correlation between higher overall diet quality indices and a reduction in all-cause mortality. Patients adhering to Mediterranean-style, prudent, or guideline-concordant diets consistently show lower all-cause mortality, particularly within the breast and colorectal data sets. The data fragments when clinical focus shifts from holistic meal patterns to single variables. Certainty collapses completely when researchers attempt to isolate single foods or specific micronutrients, like dietary vitamin D, isoflavones, or red meat. Single nutrient associations rarely replicate uniformly across different cohorts. The data is too methodologically fragile to support specific clinical prescriptions for single food items. When we shift from mortality outcomes to rates of cancer recurrence, the dataset separates completely. The evidence linking any specific dietary intervention to the prevention of cancer recurrence is substantially weaker and highly inconsistent across all measured categories. The only notable caveat in the recurrence data is a recognized unfavorable signal associated with alcohol consumption across mixed survivor populations. Patients eat diets, not isolated nutrients. The data proves that the only defensible clinical intervention is guiding broad structural pattern changes rather than micronutrient reductionism. Returning from the theoretical data to the physical reality of a hospital reveals a structural problem. Having a clinical guideline does not guarantee its execution. The primary point of failure in oncological nutrition is a systemic delivery breakdown. This systems map illustrates the standard survivorship care pathway. Clinical intervention usually stops with generic dietary handouts, a mechanism insufficient against biological constraints. Patient adherence is severed by 2 clinical friction points: limited consultation time and lack of outpatient reimbursement for registered dietitians. The data supports a tiered clinical model: broad, plant-forward guidance provided universally, paired with financially supported dietary referral for high-risk survivors. Replacing the failing pathway requires structural interventions like medically tailored meals, produce prescriptions, and integrated RD workflows. Food as medicine systems must supersede unsupported verbal advice. Observational dietary data will never reach perfect causal certainty, but imperfect data cannot justify clinical neglect when a patient's metabolic baseline is collapsing. The policy mandate is clear. Oncology systems must stop merely asking what survivors should eat and engineer the clinical infrastructure necessary to make evidence-based eating feasible.